All right, we'll be getting started in about 30 seconds. We'll let everybody else filter in and we will get started. So get settled in. We've got about 30 seconds and we'll be ready. So hello, I'm Dr. Jane Morgan, and I am here on my Stairwell Chronicles Live, where we discuss a lot of important health topics for the community and for you. We do these Stairwell Chronicles Live, these 30-minute versions, periodically, once every 2 or 3 months, where we really have a special guest and we can have an in-depth conversation about a particular topic. So this time we have Dr. Jonathan Reiner with us. And let me give you a little bit of just a personal background. He and I trained together at George Washington University in Washington, D.C. And I always liked him, was always fond of him. He is a cardiologist extraordinaire, but he was actually a cardiology fellow extraordinaire as well. He has stayed at GW. I have gone off to a lot of different things, but he found his niche early and has stayed at GW and is now really leading their cardiology efforts there, is so smart, is so grounded, is so dedicated to medicine, to cardiology, to patients, to health, and also to GW. So it is a great honor to have him. I also want to say that as we were going through really the height of our COVID pandemic, he was one of the calm, stable, learned, experienced voices of COVID, making certain that we had good information and making certain that we understood what was going on with the vaccines. I know quite a few of you follow me, but Dr. Reiner has a huge following, and also you can find him on Twitter. Jonathan Reiner, Dr. Jonathan Reiner, you can find him on Twitter, but quite a few people absolutely benefited from his knowledge during the COVID pandemic. So we absolutely want to applaud everybody who's on the forefront of these public health efforts. So today, we are going to talk about these weight loss drugs that everybody's talking about. Ozempic, Wegovy, Mounjaro. What are they? What are we doing with them? Why is everybody looking for them? Why is there a shortage of them? Can diabetics even find them? And so I thought we would start really with Dr. Reiner giving us an overview of what are these drugs. They're all injections, by the way, so far. We don't have a pill yet, all injection forms. So I want to start with Dr. Jonathan Reiner. And by the way, I'm going to call him Jonathan, and he's going to call me Jane during this. So we're going to start. Jonathan's going to give us just an overview. Let's level set. What are these drugs anyway?
Well, Jane, thank you. First of all, thank you so much for having me. And what I don't understand, though, is that even though we trained together all those years ago, how come I'm the only person who's aged? You look exactly the same as you did in 1994.
Okay, so everybody now knows why I love this guy, right? It's not hard.
So thank you for having me do this. This is a ton of fun. So to step back for a second, what we're really talking about is a class of drugs that are really about to explode. They're really exploding in the United States for the treatment of what is really an epidemic in this country, which is obesity. So if you look at the United States compared to the rest of the world, so look at the United States compared to Europe. I just came back from a trip to Europe. In Europe, about 17% of adults in Europe are considered obese. The United States, that number is like 30%. So 30% of adults are obese. And if you add on people who are overweight, it's probably more than 40% of adults are either overweight or obese, as measured by body mass index. That's basically a way to sort of standardize how we look at the amount of fat that a person has. And it basically puts together a number based on your height and weight. BMI over 30 basically being the definition of obesity. And we've had a variety of treatments over the years to try and get people to lose weight, behavioral, pharmaceutical, and surgical. The most effective is probably surgery. Bariatric surgery, offers people the potential to lose, between 30 and 40% of their body weight. Behavioral therapy, just trying to get people to exercise more and eat smarter, doesn't always work that well. And we tend to only be able to get reductions in weight of somewhere between 5 and 7%. So there's been this need for something in between to get, something that's not as invasive as bariatric surgery and more effective than just trying to get people to eat smarter and go to the gym. And that's where these drugs come in. And, the drugs that Dr. Morgan has just described fall into a category of drugs called GLP receptor agonists, glucagon-like peptide receptor agonists. GLP-1 is basically a hormone that is secreted mostly by cells in the gut, and this hormone is secreted when blood sugar goes up, while you're eating. And the hormone stimulates essentially cells in the pancreas to release insulin to lower the blood sugar. But this hormone has other effects. It also has an effect to slow gastric emptying, slow the emptying of the stomach. And it also has effects to curb appetite. Not just done because the stomach is more full, but we're learning more and more that these drugs also have effects on the brain to really make you want to eat less. And when these drugs were all developed initially for use in patients with diabetes, and what they found is that the drugs were effective in lowering, blood sugar, but people lost weight. And so companies started looking at whether these drugs could be used in non-diabetics for weight loss. And the studies have been breathtaking. In fact, the ability of these drugs to reduce weight seems to be even better in non-diabetics than in people with diabetes. And as a whole, if you think about it, there is the potential for somebody with obesity to lose 15 to 20% of their weight by taking one of these medications, usually given as an injection once a week. And now the use of these drugs like Ozempic and Wegovy and Rybelsus are becoming increasingly used, in many cases off-label, for the use for weight loss.
Okay. Which means when he says off-label, that also means that doctors have some culpability, because that means they're also being prescribed off-label. And so there's some controversy with that, because certainly obesity is a health risk. But all of them are not FDA approved for weight loss. And yet they still are being prescribed off-label. And so the question that we have is, as we are looking at these drugs, as Dr. Reiner has said, that they can sort of improve satiety, so how quickly you feel full. They work in the brain in an area called reward centers. And so the question has also been, is there any crossover as well? Because there have been anecdotal reports, meaning patients talking to their physicians, that, oh, doctor, I don't really have a desire to smoke anymore, or I seem to not want alcohol anymore. And so that begs the question of, will they have crossover effects into other types of behavioral or addictive addictions, as well as, you can begin to expand it into all types of things, including perversive behaviors. Can those kinds of things be controlled, especially if perversive behaviors can cross over into criminal predatory behavior? So there's a lot of, there are a lot of questions to be answered. And again, these are anecdotal. So one of the things, something just to chomp on, one of the things we kind of want to talk about is when you lose all of this weight, as Dr. Reiner has said, do you have to take these now forever? Or is there a plateau where beyond which there really is no further benefit? And after you get off it, what happens? Are you able to control your weight? So I'll go with you, Jonathan.
Well, I think, well, first of all, it is fascinating to think that these drugs may also be able to help regulate, obsessive compulsive behaviors or drug addictions. So we'll see much more of that going forward. But the drugs work for weight loss. They're not without side effects, and you and I could talk about that in a minute. It looks like there probably is a plateau at about 20% of weight loss. This may differ from person to person, and as I mentioned earlier, it probably differs whether the person has diabetes or not.
Mm-hmm.
So people will likely plateau at some level, which is almost certainly unique to that person. And it does look like, if you stop taking the drug, your weight can come back on.
Which is expensive. It's an expensive drug.
Now, we should talk about that too. So the drugs are really expensive.
Right.
So Ozempic costs over $1,000 a month if you were paying for it out of pocket.
Right.
And
that's 4 injections, right?
Right. For a weekly injection, 4 injections. So a month of Ozempic is about $1,000. And because the drug is expensive, insurance companies try and throttle their use. So off-label use of these drugs will not be largely reimbursed by insurance companies. There is, a Wegovy, which is basically the same drug as Ozempic, does have a labeling for weight loss, but probably all of the drugs in this class, will have weight loss effects. So the drug is super expensive. People who are on Medicare are finding that they quickly find the donut hole in their insurance when they take this drug for a couple of months, and weight will come back if they stop taking it. We were talking before we came on about there are dozens of shady websites that sell knockoff weight loss drugs, labeling them as for research only. They sell just the powder, and they require the buyer to sort of reconstitute it. Do not buy knockoff drugs that you are going to inject into your body.
Right. And compound it. And Dr. Reiner just mentioned compounding as well. These are not drugs you want to compound.
No. Do not buy knockoff drugs. We don't know what's in these vials. We don't know if they're contaminated. We don't know if the vials are sterile. We don't know the potency or the purity of the drugs. Do not buy knockoff drugs. And the FDA is starting to crack down on these very, very shady vendors. But the market is there. I think Ozempic has sales this year of something like $8 billion. Novo Nordisk has become basically the biggest company in Denmark, one of the biggest companies now in Europe. So the market for these drugs in the United States and around the world is huge. But these drugs don't come without side effects. So I don't know. Are you seeing some patients come into your place, Jane? Now I'm switching to Jane.
Right. That's okay. Yeah. And this is what we want to talk about, because there's actually, a big class action lawsuit about the gastroparesis. So what Jonathan talked about earlier, some of the side effects are also the benefits. So it slows digestion, so slows gastric emptying, meaning it slows the passage of food through your intestines, right? We call that gastroparesis, which is a benefit. So that means it slows down the processing of the food to help you lose weight. But in some people, it can be so slow until it has paralyzed the gut. And people sorry, I don't know what's happening. Let me see if I can everybody mute themselves, please? Thank you. I'm going to try to mute you. Please mute. Okay. So that's the benefit, but it's also can be a risk. All right, please mute. It also can be a risk as well, in that people can end up with chronic vomiting and not being able to pass food, and the food is kind of sitting. And so that's, you know, as we study these, that's been a side effect. It hasn't been a common one, but it has been a side effect.
Yeah, and you're right, and it's as you said, it's the subject of a lawsuit now. But you know, every drug has side effects, and the nausea and vomiting with these drugs is a known side effect. For most people who take a drug like Ozempic or the sister drugs in the same class, most of the time these drugs are given in a lower dose to begin, and then the dose is slowly ramped up to help people sort of gain tolerance. And most people will gain tolerance. The severe vomiting that is alleged in I think in that lawsuit is a rare complication that comes from basically the stomach essentially having severe gastroparesis and just not emptying well at all. That appears to be a very rare side effect. Are you seeing patients in Atlanta who, rather than going for bariatric surgery now, are being started on GLP and agonists as a first step before having surgery?
As a first step, that's right. Before bariatrics, as a first step, it's considered less invasive. But it's very expensive. And we still don't have a lot of these questions answered. And long term, similar to bariatric surgery, actually, there can be some rebound. Bariatric surgery as well. Patients can regain the weight. So it's about behaviors. So we continue to, understand these drugs. I did a media interview just either yesterday or the day before about berberine, which is a pill, a supplement that's being touted on TikTok as the Ozempic of pills. But just as Dr. Reiner says, you buy it online, you don't know what you're getting. It can be compounded. There are varying degrees of these active ingredients, none of which are being approved by the FDA. Supplements, by the way, have no FDA approval, none. So you're just out there in the wild west. And so think about that when you are looking at knockoffs or something that may be within your budget. It also is outside of the purview of the Food and Drug Administration. So there are no safety guarantees, and there's also no data on it that has been verified and validated by the FDA. So we have to remember that. I have a question for you, Dr. Reiner. I once lost a significant amount of weight, aided by a medication I was taking for a different reason. When I got off the medication, I gained all the weight back. Is that still the same thing?
Well, it's hard to know. And it's hard to know what medication you are taking. There are obviously medications that can result in unintentional weight loss, particularly if the medication isn't being properly regulated.
Right.
But it would be hard to know based on just sort of that kind of generic question. One thing that I was thinking about is I think we're starting to learn that people you know that obesity is primarily a biochemical problem, not a behavioral problem.
Hmm.
And I was reading something this week
So that's
where
interesting. Okay.
where basically someone said that you that that overeating doesn't make you obese. Obesity
Mm-hmm.
makes you overeat, and it's the biochemical syndrome that leads to obesity is what is making people overeat. And I think for too long we've looked at folks who are overweight and have essentially placed the burden for their illness on them, rather than, I mean, it would be as if you look at somebody with cancer and basically just sort of blame their lifestyle, for their, you blame their own lifestyle for the cancer, rather than understanding that they have a disease. And I think what these drugs now show us is that obesity is very much a biochemical disease that can be modified now with some very new, very exciting drug therapies.
Mm-hmm.
And just relying on behavioral modification, which has always been so disappointing, now we understand why, because this is a biochemical hormonal problem.
Yeah, that's interesting because there's been more of an explosion of obesity in the last 20 years. And so where is this, from where is this emanating? And does it start early with overeating and it triggers this biochemical mechanism, and now you're kind of on this loop in which you can't get out of? Because one of the things that we have noticed is that there's also an increase in cancer in younger and younger people, specifically in this demographic now that's 30 to 39 years of age. And for the first time in modern history, people who were born in the 90s have a lower life expectancy than people born in the 80s. And it has also coincided with 20 years of an explosion of obesity. We have more obesity now in the United States than we've ever had. And the question is there something called toxicity of obesity? In other words, in previous generations, generally, human beings didn't start to gain weight until they were reaching middle age. Metabolism was slowing, hormonal changes. So in their fifth or sixth decade of life. Now people may be overweight when they're in their 30s and in their 40s, and they've already had 3 and 4 decades of consistent obesity, whereas previous generations did not have that and didn't remain obese for that long of time. They had obesity later in life. And so we're starting to take a look at that. And so I think all of these questions, I think we see everything, many things coming at it in a lot of different angles. We've got these weight loss drugs. We're trying to understand biochemistry versus behavioral. We're trying to understand what is this increase in cancer. It's coinciding with obesity. What's happening in the last 20 years, diet, processed foods, infrastructural racism, vulnerable populations. All of these things coming together, health equity,
food deserts,
pharmacy deserts, deserts of green space and parks. And how does all of this come together? And when we look at these, the weight loss drugs are, I don't know. I'll ask Dr. Reiner, do you think it's a cure, or is it a Band-Aid? Is it an opportunity, or is it sort of a false dream? And
I don't think it's a false dream. I think, well, look what's happened over the last 40 years in the United States. We have changed, over the last half century. We've changed how we eat in this country.
Mm-hmm.
And in many parts of the U.S. and I live in D.C. You live in Atlanta. There are parts of the District of Columbia where it can be hard to find a lot of vegetables to make for dinner, but it's really easy to find something relatively inexpensive with a high caloric content that tastes good, and a very high sugar content, salt content, at a fast food place for just a couple of bucks.
Right.
And that kind of ready accessibility to relatively inexpensive foods with the wrong nutritional characteristics has certainly contributed to obesity in the United States. But I think that there are biochemical differences between people that perhaps make some folks more susceptible to obesity than others. And looking at how people respond to these drugs, it looks like a lot of this is biochemistry.
So in the last few minutes that we have, and I can't believe this conversation goes so fast, where do you see these drugs fitting in? Is this just the tip of the iceberg? Or is a tsunami coming of all types of drugs flooding the FDA? I know, absolutely, I know different drug companies are moving towards pills. Are we on a slippery slope, or are we really on to something to regain the health of America, or are we just on a slippery slope?
I think a tsunami is coming. It doesn't take a gigantic amount of weight loss for you to see beneficial effects. Losing, even 5 to 10% of your weight can lower your blood pressure, can lower your cholesterol, can lower your glucose. And we've known for a long time that doing all of those things, which the kinds of things that you and I do every day when we're in clinic, doing that will reduce the risk of cardiovascular events. And that's actually the final piece that you and I should maybe talk about, is that these drugs, which were first identified to treat diabetes, to lower blood sugar, are now showing the ability to reduce cardiovascular events, heart attack, and stroke. So what we're seeing basically is sort of the full circle. The drugs reducing, improving diabetes, reducing weight, now reduction in weight, resulting in reductions in blood pressure, better cholesterol, and all of that translating into the important heart reduction of reducing heart attacks, stroke, and dying. So I think this is the beginning of literally hopefully a beneficial tsunami in this space.
So one final question in the chat. Have you seen an increase in obesity since COVID-19? And I'm just going to kick that to Jonathan, but I will start in that we know that people didn't get slimmer during the pandemic for a number of reasons, right? We were home a lot, and we were sedentary, and we were eating, and we were drinking, and all kinds of things. But on a broader scale, maybe we will ask Jonathan, those types of restrictions aside, maybe what you're getting at is, has COVID impacted obesity? Maybe patients who have contracted COVID, have you noticed that they I think it's a great question.
I actually don't know the answer to that. We certainly have seen an uptick in cardiovascular disease during COVID. We know that this virus is a vascular disease, and it causes inflammation in the vascular space. It promotes clotting in the vascular space. But whether or not it promotes obesity on a biochemical way, that's an excellent question, and unfortunately, I don't have the answer to it.
Right, and that's what we, and I think Jonathan hits it right on the head. We're still learning so much about COVID, but something he said that was really specific that you should note: COVID was a vascular disease, it was not a pulmonary disease, and we know that it's impacting the lining of your arteries and what that means. And so we know that they're cardiovascular or heart outcomes and implications. Whether or not people who've had COVID now tend to be heavier or are gaining more weight, that's something, a question we'll have to see. But we do know that as people were sequestered, as a nation, we got a little larger. And so we're going to close out. The time went so fast. I'm so happy to have had Dr. Reiner here and all of his experience. I didn't know if there was anything you wanted to add. And let me just tell you this about Dr. Reiner. He's on CNN all the time. I think you are a medical correspondent, or I don't know.
I'm still a medical analyst.
A medical analyst. He's a medical analyst for CNN. He's on all of the time. He gives really great sound, very direct information that is easy to understand. And I see him and follow him all the time.
And I see you on CNN as well. And I see your son on CNN.
Thank you. So I didn't know if there was anything you want to close and leave us with regard to these medications, as we are, kind of on the cusp of what's coming with everything. How should we be thinking about them?
I think this is an exciting time. I think, as a physician who's practiced now for almost 30 years, to be able to offer potentially going forward a well-tolerated drug that can give a person a really meaningful reduction and durable reduction as long as they take it is very exciting. The challenge going forward is to understand how best to use these drugs, in whom, who should get these drugs, and hopefully have them in an affordable way so that we can make this therapy available to everyone, not just those folks who can afford them.
Get good insurance coverage. That's great. And I like that you say they're well tolerated. All right, everybody. Thank you for coming on a Friday afternoon. I hope you learned a lot. You can always shoot me some questions. And Dr. Reiner, what's your Twitter handle? You can follow him. He has 65,000 followers. They're following him for a reason. What's your Twitter handle?
@JReinerMD.